My name is David Kulik. I'm co-founder of Adaptation Health, which is a buyer-side Medicaid incubator. You can find out more about us afterwards. I'm going to let the panelists introduce themselves in just a second. From housekeeping, this is being live streamed, so welcome to all the folks that are tuning in. And there's the URL that you can text to other people who are not here. I'm going to hand it over to Tim Lash of West Health. He's the Executive Vice President of West Health and the President of the West Health Policy Center for some opening comments.
Great, thanks, David. It's great to be here today and really looking forward to the discussion with the panelists. As David said, I'm Tim Lash, Chief Strategy Officer at West Health. I also lead our DC office. And for those of you not familiar, West Health is a family of nonprofit organizations focused on two things. One, lowering the aggregate cost of healthcare, and two, identifying and advancing delivery models that are more aligned with the needs of an aging population. And obviously, two of those themes will transcend many of the discussions and models that we're advancing today. As we head into the midterm, healthcare overall has become the #1 issue. In fact, West just completed a study, a representative sort of voter study across the country with NORC, and sort of the challenges associated with healthcare, and specifically the cost of healthcare, outranked jobs, the economy, national security, immigration, trade, #1 issue. And when you start to dive into the data underneath it, the populations that we're talking about today, in many ways, feel the pain points or the failures in the most acute way. And in care, we see that in surveys that shows up with an incredibly high proportion of individuals, indicating that they're either foregoing care, things like prescription drugs, because of the cost, or even in some cases, indicating that they fear the cost of a serious illness more than the serious illness itself. And that really is quite unacceptable. And when you think about Medicaid covering more than 76 million lives across the country, it should be at the center of transformation. I think states know all too well how to operate in a more resource-constrained environment, and as such, I do think we've seen some bright spots, and we'll talk about some of them today. I think the trick is going to be being less reactive and more proactive with these types of discussions. When we see innovation as a response to circumstances that have been put on top of us, you can have an impact, but often it's incremental. But when we learn and identify where those pain points are, what models are working, proactively address them, I think we can really get at widespread transformation. And that really has an incredible opportunity to lower the cost associated with providing care, generate more efficiencies, and ultimately improve the quality of care that we deliver. So we're really excited to hear from the panelists today. Thank you to Adaptation Health, California Health Foundation, and the Medicaid Health Plans of America. And thank you to the panelists for leading away and showing us what the future can be.
Thank you. So thank you, everyone, for coming to our panel today. And we're going to go through just real quick and do quick introductions. And then after that, each member is going to talk a little bit about what they do. So I'm John McCarthy. I was the Medicaid Director for the state of Ohio. And then previous to that, Medicaid Director here in the District of Columbia. And now I'm a founding partner with Spire Healthcare Strategies.
Good morning, I guess it's still morning. I'm Melanie Bella. I'm with City Block Health. I work on partnerships and policy. My background is in Medicaid and duals. I was a Medicaid director in Indiana a while ago, and also was at CMS, where I started and ran the duals office for about 5 years, and now I'm part of the founding team at City Block.
Great, I'm Justin Dangle, co-founder and CEO of Ready Responders. I have a background in entrepreneurship. This is the first thing I've done in healthcare, and I've learned quite a bit about the system along the way. It's a different area than anything else I've worked in before.
Good morning, I'm Alex Denny. I'm the CEO of Kaleidoscope Care. Previous to that, I built a Medicaid patient engagement company called Consejo Sano that focused predominantly on Spanish speakers.
Thank you. So, Melanie, you want to start out a little bit about what you all do?
Sure. So as I mentioned, I'm with a company called City Block Health. City Block is a relatively new startup. We're currently live in Brooklyn, in New York. I'll tell you a little bit about our origin story, which I think is relevant to the innovation piece today. So City Block was incubated within Sidewalk Labs, which is part of Google Alphabet. And basically, Sidewalk is trying to make investments in improving communities across the country and wanted to figure out what it could do in the healthcare space. So created an entrepreneur in residence opportunity. Our CEO was selected to be the entrepreneur in residence and basically said to them, if you want to do anything in healthcare, you've got to do it around publicly insured populations in dense, impoverished urban areas. Like otherwise, don't even bother. And they bid, which has been interesting, that the tension between sort of the techie VC world and meets Medicaid reality has been quite a journey. But essentially, so they incubated us, we spun out, did a Series A raise, and are now live with a product. And so the product is, City Block is an at-risk provider that provides for medical, behavioral, and social services for complex populations with a focus on Medicaid and dually eligible in dense urban areas. Our model has 3 pillars, if you will. One is a neighborhood hub, so a physical space that is more of a community gathering space than it is a place to get medical care. For example, when we asked the folks in Brooklyn what they wanted, the 4 things they said, Wi-Fi, a place to charge my phone, air conditioning, and a place to get a sandwich, right? Nobody's really interested in the medical care, so we're really downplaying the medical piece and oversizing the community piece. The second piece of the model is an interdisciplinary care team, very much what you all would expect, except I would say we have our version of a community health worker, which is called a community health partner. These are folks that are born and bred, raised in Brooklyn, in this case. And what's important about them is that they are on equal standing with the provider. So they, what they say goes, and we believe they are the key to being successful in this model because it's all about building trust and engagement. And otherwise, it doesn't matter about all the other fancy bells and whistles and tools we have, our opinion. And then the third piece is a technology platform. Our tech platform is called Commons. It's purpose-built for complex populations with a focus on bringing in social data and using the social data in combination with other sources of data to guide everything from workflows to stratification to what everybody is doing on a daily basis, as well as communication with the member and anyone else that the member gives access privileges to be a part of that. So our business model is to, as I said, to take risk. All of the things that we're doing could not function in a fee-for-service environment, so risk is critical to give us the flexibility to provide for the non-medical side. Also the flexibility to make an investment that may not pay off in the immediate term. So we work with payers and at-risk providers. Our anchor partner is Emblem Health in New York, where we have worked with Emblem to identify a group of members who are complex, high risk, and also importantly rising risk in a certain geographic area, and then we work with those members as part of their benefit through Emblem Health. And so we are anxious to try this in new markets, but excited to be getting off the ground and learning there. So I think that's a quick overview.
Awesome.
Look forward to questions.
Justin?
Great. I'm Justin Dangle, and our company's called Ready Responders, and we were formed to look at some new approaches to pre-hospital care that might create alternatives to unnecessary ED utilization and support populations that need help with adherence. We launched in June in New Orleans. Over the next month or so, we'll do about 2,000 in-home patient visits. So we've been able to grow pretty nicely. We've partnered with most of the big health plans in the state, particularly United, and Aetna, and some of the other big payers, and also most of the big hospitals now. Ochsner is a particularly robust partner. And our model is relatively straightforward. We're an on-demand network of nurses, EMTs, and other healthcare professionals. We built app technology that's a bit like Uber or TaskRabbit in that providers can log in or log out when they're available. We can dispatch them anywhere within New Orleans, typically within 8 to 10 minutes. And we use this network in a few different ways. So one is our on-demand house calls program, which patients can access through the 211 system, through our hospital partners, or directly through our app. And this allows us to essentially dispatch someone to the scene. We run a series of protocols developed mostly by the Houston EMS and Fire Department called the Ethan protocols to make sure it's safe to treat someone at home. And then in most cases, we'll bring a doctor into the living room via video and provide really the equivalent of most of the things that are in scope for an urgent care visit we can do on the scene. And this is mostly at this point utilized by Medicaid patients, although we do have a decent sized commercial population, with the idea of saying, hey, this is actually better than going to wait for 4 hours at the emergency department. And as I said, we've gotten a lot of successful utilization of that. As we dove in, and I think I mentioned this is my first venture in the healthcare space, so I've learned quite a lot about the nuances. And one of the things we learned is that in order to really work on the problem of unnecessary ED utilizations and frequent readmits and so forth and super utilizers, that we needed a program that was a little bit more robust than simply house calls. And we've partnered some of the super utilizers in communities we help with the responder that lives closest to them. They'll go visit them 2 or 3 times a week. They'll do a social behavior and environmental assessment. They'll connect them with social services and run programs that are often associated in the EMS world with community paramedicine. And then we continue to visit folks and make sure that they have their medicines, that we do med reconciliations, all the things that you need to do to help folks stay on course. And then finally, we've recently launched our transitional care program, and this is in conjunction with Ochsner and some of the other hospitals in New Orleans, where we're taking patients, particularly scoring them based on risk and reaching out to those patients that are at material risk of a 30-day readmit, offering them an in-home visit, connecting them with a doctor, making sure that they have a primary care physician and an appointment, med reconciliations, all the things that we do that are beyond our simple house call program. So that's basically what we do, and the results have been great so far. So across our super utilizer populations, we've really just gotten our first cohort of data. We saw a 65% reduction in ED utilization and a similar reduction in readmits. So this program works. It saves money for payers, improves outcomes. Our satisfaction scores, so I do not come from the healthcare world, I do come from the consumer internet world. And in the top bucket of very satisfied, we're running over 85% with patient encounters. So I've personally never seen that in any of the consumer world that I've been a part of. So this seems to be working pretty well, and we're looking to get into our next few markets next year. We're going to open 3 to 5 more states. Our company is not backed by Google. It is backed by Founders Fund, who is one of the more successful venture capital funds in the world. They were an early backer of Airbnb, Facebook, Dropbox, and several others. And we've got a number of other top firms in. I think the finance community's noticed that this is a model that can scale. But most importantly, our payer partners continue to be very excited about both the improvement in outcomes and the reduction of costs that the program has generated. And our patients obviously love it. So that's, I think, a good introduction.
Yeah, thanks, Jason. Alex?
Great. Yeah, good morning. I'm Alex Denny again with Kaleidoscope Care. Our focus is really on rising risk populations, and people define that different ways through pop health and the literature. We generally see it as the group of people just below super utilizers, so about that 18 to 30% of the population that falls underneath that top 5%. You know, by way of our background, our team came from a couple different places, some behavioral health and some EHR. And then a core part of the team came from a background in Medicaid patient engagement. At the time, we were predominantly speaking with limited English proficiency populations, predominantly Spanish speakers, and really running programs around HEDIS and STAR improvements, closing gaps in care, and the like. And we did very well in that. We found a lot of low-hanging fruit, and then it sort of got us interested in how to reach that tier of people that weren't quite responding to those messages. And you know, as we dove more and more into the literature and kind of focusing on rising risk, it just seemed really interesting to us. You know, I think there was a lot of conversation around top 5% driving, you know, 50% of the overall spend. But actually, the numbers also show really the rest of that spend is just coming from that next tier down. You know, that bottom 50%, 60% of people really aren't on costing too much. So we really went to market with a thesis around how do we design programs that essentially fill in the gap between sort of generic SMS, you know, appointment reminders, things of that nature on one side, and much more staffing heavy, extremely robust kind of complex care management programs on the other. So that's Kaleidoscope Care. What we do is we work with population health teams, EHRs, a variety of other sources within payers or providers. We aggregate that data and we turn it into personalized care plans at scale. That is really focusing on relationships to primary care teams, behavioral health teams, and then, depending on the payer provider's interest, building what we think of as a skinny network of community resources in their neighborhood. Pretty interesting research around the idea that for populations that are rising risk, it's not really about boiling the ocean and mapping every single social determinant partner. It's really about putting the core top 10% of those partners in front of them at the right time. So predominantly, we've worked with providers to date. We've really focused on a few different programs. One is lowering readmits, 30-day readmits, connecting to referrals within 7 days, and then really focusing on transitional care programs. But generally, all the populations that we're working with have some combination of 1 to 2 chronic conditions or behavioral conditions on top of some precariousness around their social status. So that's really what we do. And yeah, looking forward to sharing more.
Thanks. So it's interesting, you've got former Medicaid director, myself in 2 places. Melanie was a Medicaid director, got a Medicaid director, former Medicaid director in the audience. And of course, we all thought as Medicaid directors, we were super innovative, and the outside world, yeah, there's the laugh, right? The outside world never thought of Medicaid as innovative generally. It was just kind of tension between the two of what's innovation, what's not innovation. But there has been a lot of innovation in Medicaid over the last few years in different areas, and especially in these populations. I know myself, I did a duals demo in the state of Ohio, fully integrated program to kind of tackle the issues that were brought up in these areas. So let's talk about the positives here for a second on the Medicaid side. You all have talked about what you're doing in there. Other people look and say, Medicaid is and states are the incubator of innovation, little laboratories out there. So can you talk a little bit about why you are focused on the Medicaid population and where you see that innovation coming from on the Medicaid side? And Alex, we'll start with you.
Sure, happy to. I guess the interest on our end kind of came predominantly from 2 different places. One, I think it was a place of passion for the team, easily. It was a place that our team had always been interested in working, and building our last company really at the same time as the ACA rollout, Medicaid expansion. It was a natural opportunity. But I think more interestingly to us was also the idea of mobile penetration rates rising so quickly. And I personally came from a background in doing international development technology, international development finance, and a lot of that thesis is always, rather than onboarding people to the old way of doing things, suddenly you see this in every emerging market. People have cell phones at incredible rates. Just let them leapfrog to a new standard, whether that's mobile payments, mobile care, et cetera. So I think a lot of what we got interested in was looking at a Medicaid population, which, contrary to, I think, popular belief, probably well known in this room, extremely high rates of mobile, everyone depends on a mobile phone. Vast majority of people have smartphones. So I think we saw it as an opportunity similarly between the policy change and the tech change that sort of went hand in hand with it. There would be an idea that we could onboard people to sort of a new standard of services rather than simply trying to get them back into a traditional rhythm.
Justin?
Yeah, I guess the reason why I think Medicaid is the bulk of our business at this point is largely because it's the population that most uses the ED, the emergency department, for lack of alternatives, and a population that in some cases struggles the most with adherence. So we built our program with the idea of helping everyone, and that continues to be the approach we're taking. But it turns out that Medicaid patients are the primary utilizer of our services. And when it comes down to it, Medicaid patients are 3 times more likely to go to the emergency department than a commercial population. And there are similar statistics around some of the adherence challenges. So as we look at who needed the help the most and which payers, I think, initially were most focused on the problem set that we're solving, I think that's how we ended up in Medicaid. And I think we found, particularly Medicaid directors around the country, as we've been in Louisiana, but also in some of the other states that we're getting ready to go into, the Medicaid directors seem to be particularly focused on solving some of the important problems of access and providing alternatives that can both materially improve outcomes and the experience for patients and also lower costs.
Molly?
Yeah, so I guess first and foremost, it's just a mission thing. I mean, the people that are part of the founding team, this is in our DNA, these populations, and we really we're frustrated with the fact that there is a lot of investment going into Medicare populations and others, and not very much going into Medicaid. And so saw a real opportunity to raise our hands and say, we actually want to take risk on this population. We think we can make a difference. And the place to do that is just Medicaid. I mean, the states have the flexibility and the health plans now have the incentives with more and more of the complex populations having moved into managed care. It creates real opportunities, I think, for partnership and innovation in ways that didn't necessarily exist in the past.
Now, flipping it over to the other side, we talked about the innovation and why you got in there. But as people laughed earlier when I talked about this, often you talk Medicaid, there are barriers. There's barriers to entry. There's barriers to talking to health plans, Medicaid directors, and some of those areas. Justin, can you start out? What are one of those barriers you ran into, and how did you overcome it? What did you do to get past that?
Some of one of our biggest advantages and disadvantages as a company has been our relative naivete as we started the business about what it takes to do stuff. And I think that there are some barriers in innovation in healthcare that are there for good reason. You know, when we change things around in the healthcare system, we're taking risk with people's lives potentially, taking a lot of financial risk and taking legal risk. And so I think contracting and developing new programs is always going to be slower in the healthcare space than it is in, let's say, the consumer internet. I think that some of the challenges that maybe, and there's some other structural challenges, obviously plans have sort of asymmetric incentives, is that they can take if something goes wrong, they take the full brunt of the loss. If something goes well, they can't always realize the full financial upside. I'd like to see more risk-taking and more value-based contracting going on. It's been my experience in this and some of the other stuff I've seen that process can be really slow, and that our company started moving a lot more quickly when we figured out how to live within the confines of a more traditional payment model than I think when we originally started. So I think that if Medicaid innovation were going to accelerate, looking at more innovation around payment models, accelerating contracting processes, and so forth would be a good thing. I think we as a company have come up with some ways to deal with this for our specific entity, but a lot of the models that I see as a seed investor or a potential partner, I think, are constrained by some of the challenges around things that, again, probably don't affect our company as much, but affect a lot of really innovative models, is just the ability to contract, to create real value-based models and so forth.
Alex?
Yeah, I mean, I think at least in terms of the populations that we serve, there's certainly, one of the challenges is there's already a mandate for inclusion and care, writ large in Medicaid. And so trying to pitch something as, a blind spot or uncovered, it's I think rightly met with some resistance. People have been working hard on this for a long time. I think at the same time, there's, we've been pleased just to see that people are willing to sort of, I think innovation is such an overused word, and it can mean so many things. I think sometimes it means sort of a new model for sort of tackling an existing problem. I think we've been pleased to see plans, really looking for innovation in terms of new signature initiatives, that you can kind of build a process around. So, we've been excited just at the response on that level. Yeah.
Mm-hmm.
Yeah, I'd start out by saying, we haven't had any direct problems with a state. New York's Medicaid folks are wonderful to talk with. The place I'd name two things. One is when you are changing care for these populations for the better, if you're doing it well, you are disrupting the status quo in a way that vested interests are, things are changing for them. And many of those vested interests have supporters in the legislature, which trickles down into what the Medicaid agency can or cannot do. So you're sort of up against that in a way. I think particularly some states more than others. John and I are nodding. I think our states had a lot of that. The second piece is, I guess, I think government in general and states too, when programs are put in place, we just keep adding on. You don't really ever step back and say, let's take something away, or, it's like, so you get a lot of like stuff that's built on a legacy of programs. And as a result, in these worlds, I think you can end up with well-intentioned state policy where you have like a bunch of money going towards, call it care management resources, but no sort of rationalization of those resources. And so when you're trying to come in and figure out how to make something better, you're sort of dodging this kind of maze of things that have grown up over time, and you run the risk of just adding to the duplication and putting more money to it instead of like kind of stepping back and trying to make it better and freeing up resources to take care of other things. If that makes sense.
I want to touch on that a little bit. As Medicaid director, my goal was to improve the health outcomes of the individuals on the program. That was first and foremost. But obviously, it was also to control the growth of the spending in the program, and that was a big push. The governor that I worked for, Governor Kasich, and then the mayor in D.C., Mayor Fenty, they both were concerned about the growth of the program and those different pieces. That led to a lot of innovation over the last few years. Value-based purchasing is a big one, and Justin, you brought that up, is move to value-based purchasing. Ohio took a specific direction. Ohio, Tennessee, and Arkansas took a specific direction, mandating what that would look like. In other states, they have basically put those mandates on the managed care plans. And I know most of you are working with managed care plans because of the flexibility over there. The concern that's always come up with managed care and value-based purchasing was in the short term, you get those savings, but what does that look like over a long period of time? Does the Medicaid agency say, hey, you saved a bunch of money, we have 50-50 shared savings. That's terrific health plan. I mean, I'll start at the health plan level. The managed care plan cuts that trend rate from 3% to 1.5%, so they keep half that the first year. But I take that away the next year, right? And so then the next year it shrinks, which then they turn around and go to you all and put this, tighten down your contracts. What is your advice to states from that side? Because you are the ones out there innovating, doing things, looking at new ways of contracting. What would you say to a state around this view of how should contracting and value-based purchasing look like going forward on that side? Melanie, I'll start with you on that one.
Well, if I was queen for the day, I would change the entire Medicaid financing formula because I think it's antiquated and it does not conducive to the types of innovation. And as a result, it leads to short-term decisions like, cutting rates year after year, even kind of that penalizes folks that are doing positive things. So if we have to work within the existing financing structure, I guess it's all about, to me, states have got to get cut into, right? They've got to get a piece of the pie, and there's got to be some way that they're benefiting by allowing this innovation, and that there is some sort of reconciliation on the back end that is in preventing them from continually cutting rates year after year on the front end. And some ability then to recognize that there's an investment that has to happen over time, but the state has to share in that in more creative ways than just like ratcheting the rates and calling them actuarially sound.
Yeah.
I think it would be good if you were queen for the day. So I'll work towards that end. But then I would agree, and I obviously there's a natural tension that you've raised, but I think Medicaid directors have a key role in supporting and introducing innovative concepts to MCOs. That's been a part of our rollout as a company across the states we're in and the states we're going into. And I think that's critical. And I think that over time there's an RFP process that can pick up the benefits that are developed within cycle that actually lower and improve costs. And I think Medicaid directors could play a key role in creating the energy at the MCO level to make sure that they are, in fact, innovating and using their value-added service dollars in ways that potentially point to a better system.
Alex, anything?
Yeah, no, I think those are all excellent points. I think part of this challenge is a focus on the investment and the narrative around, if we're going to move to value-based care, there has to be a big focus on preventative care within that. And obviously with a population that churns frequently, it's, you can't just say we solved this last year, therefore, we're adjusting, the goalposts. So I think that's certainly a big part for us. I mean, I think there is some interesting new research around, for instance, a lot of the Medicare ACOs, pretty much all the savings they're seeing, to the extent that they're successful, are coming from rising risk populations. It's not just better management of that super utilizer population. So I think all this kind of happens in tandem. Maybe, as we get better research on what it really looks like to look at things from a value-based perspective, that will continue to shift.
So I've been in Medicaid for over 22 years. So before I was Medicaid director, I was a consultant and I was helping states reform their Medicaid programs, and I always joke around. I worked in a couple of different states, and one of them was Hawaii. It was great working in Hawaii and being there, and you wake up, you're on the beach, and I woke up in some other state capitals that aren't as great as Hawaii, but again, working through their programs and different areas. Now is a very innovative time from the standpoint of outside funding is coming into the Medicaid world, which is great to see. I mean, a part of it is just, I believe, part of it is just the healthcare expenditures in general are growing, so that's an area of growth, so people are entering into this area. But it's great to see that private sector side coming into the Medicaid world, which if you go back years, it wasn't there. Any investment usually came from the state giving additional monies to a hospital system or provider group or something like that. So it's great that that additional investment's coming in, because I do think that there's the possibility of returns on the Medicaid side as a business opportunity. As much as people talk about low rates in different areas like that, yeah, but there's still a lot of money in the system that can be used in different ways and in innovative ways. But one of the things that comes up, and it's not just for the Medicaid directors, it's also for the plans, is when you do something new and you take a risk on the Medicaid side, and if it goes wrong, your picture's in the paper, they say, not great things about you. I left Ohio in 2016. Ohio's going right now through an interesting period where the newspaper is focusing on the pharmacy benefit manager, the PBM. And unfortunately, they took one picture of the director and the head, a deputy director, and that one picture shows up every single time in the newspaper and on the website. You see them standing there, and they have not great headlines around that. So every now and then things don't work, and I often pushed my staff, and I told the governor that, hey, we're going to take some risks, and some things aren't going to work, but we got to work through those because I think we'll have more things working. But from your view, right, from the three of yours view, you're innovating, you're doing it. What can you say to the state, to the health plan around how do you look at this new innovation, why yours is going to be different, but if there's something doesn't go right, how is it that you guys help mitigate what happens around those areas? What does that look like when it doesn't go perfectly? And Alex, I'll start with you on that one.
Sure. Well, I think part of it is really just staying close to a narrative around that, the future of the status quo in some, respects would be a failure, right? And I think everyone in this room is very fluent in that, but just really always framing it's like, that we're already trying to react to a problem. We're not creating the new problem. Problem is expenditures are going to go through the roof, and this population isn't getting the care they need, more importantly. So I think to some extent always framing around the idea that we have to be trying new things because we're actively solving a problem. It's not, just innovation for the upside, but it's really we're trying to get away from, the pain that will be felt at state budgets all around the country. So I think that's the big narrative. And then, from our side, I think it's really trying to bring the patients themselves from these populations more into the fold, really trying to develop ongoing dialogues with them, screenings and assessments, both around things directly related to care, but also lifestyle, social services, things of that nature. And a big priority of ours is saying we will continue to learn over time. The idea is not to sort of hit a home run first time at bat, but rather create more of a learning process where we understand why patients are making the decisions they are en masse. And at the very least, we can always be giving that back to you so that your decision making improves, in the years to come.
Justin?
Yeah, I guess I would say from the entrepreneurial perspective, coming into the space, the bar should be really high. And, amongst companies that are trying to do things in this space, we should all work really hard and really be well prepared when we go in to see a Medicaid director, a Medicaid plan, because we're dealing with complicated things that affect millions of people's lives in really profound ways. And so I think in our team, we kind of have a rule that if something goes wrong when we see a Medicaid director and MCO, we don't go complain about them. We go figure out how to do a better job, explaining what we're doing, documenting what we're doing, risk managing what we're doing, understanding the complexity of the issues we're dealing with, understanding what other solutions are in the market. And I think that from an entrepreneurial perspective, the folks that want to really be a part of helping transform this space, I think that every presentation you ever see about healthcare and Medicaid always starts with some like very high level anecdotes about the challenges of our healthcare system. So everyone knows it. There's no Medicaid director that doesn't want to see costs go down, outcomes improve. There's no MCO that doesn't want to see it. But at the same time, there's also no one who's been in the space that doesn't understand what things look like when they go wrong. And so the bar is high. It should be high. And that I would, if I was a Medicaid director in MCO plan, I'd listen to people, but I would demand that they come in well prepared, that they know what they're talking about, that they understand the risks. It should be hard to get in, and it is. It doesn't mean that people shouldn't innovate. It doesn't mean that entrepreneurs shouldn't try, and it certainly doesn't mean that planners shouldn't try stuff. But I think that, again, that this is to me a natural tension that exists because we're dealing with healthcare and state budgets and stuff. And I think that, like I said, the standard should be really high.
Melanie?
I guess I would say transparency is really important. So being very clear about what you're doing, who you're doing it with, what you expect to see and when you expect to see it, and making sure that the state is never caught off guard. And again, in my case, like the only way I ever got anything done out of state was to have a good relationship with the legislature and the staff of the legislature. And so making sure that no one is ever blindsided, one. Two would be, that includes like really strong stakeholder work. Particularly for these populations, you better be sure that you have a good relationship with the advocacy community and the populations they represent, because that also affects whether the state, how they respond and interact with the state around some of these initiatives. And I guess the third would be financially in this situation. I mean, we are holding the bag if our bet goes wrong. And so it insulates the state to some degree. Doesn't mean that you might not still get a bad headline, but I think if people are informed and they know what you're doing and you have realistic expectations, you mitigate those chances. And you certainly, in most of the models that we're talking about, the state is not the one ultimately at financial risk. Maybe the plans are, but they're at least one step removed, I think.
Yeah, all good points. And I would like to point out for the people in the room, what we found in Ohio to be very useful tools in this is as you're launching these and you've got the good outcomes, that you try to get the good story in the paper, which is not always easy to do, but it's you write the story, you go to the reporters, and you talk about it. Because if those reporters write that good story, the first one, I should say that first story being a good one, the good work that all of you are doing in these different areas, then later on, if something doesn't go exactly the way you thought it would go, they're less likely to write that story that is, it's the end of the world story and, terrible things are happening. It's much more of a, well, what is it along the way and trying to figure those different pieces out. One of the things, and Alex, you hit on this one, when people think of innovation, talk about this in the Medicaid arena, right now, the number one thing that pops into people's head is technology. It's like technology, technology. But all of you have talked about what you've done. There's a piece of technology, but then there's a lot of other things that are non-technology related in there. Could you each talk a little bit about that balance of, is this just all technology? Is it something else? Is it social determinants of health? What are those different pieces in there? How do you view it? And then not just now, but going forward, how those things work together. Alex, you want to start with that one?
Yeah, absolutely. Well, I do think technology is it's a core part of what we do. We are very intentionally trying to design for scale. So it's not, really robust staffing models for a few thousand of your most risky patients. It's how do you move that to 20, 30, 50,000 people at least. So technology has to be a part of that. I think that's a great thing. And technology moving so fast, the ability to really run a personalized care plan at scale automatically, is there. So I think that said, by and large, all of this is just, it's about change management and workflows. And for us, we have the technology, but the goal is that it flexibly can wrap around whatever workflow is already in place. We always saw we would get buy-in from a Medicaid director. We would get buy-in from, the clinical or quality teams. But really, when we went down to an outreach team or someone like that, I mean, those were the folks who were still not aware that, we had undertaken a new signature initiative. They're still printing spreadsheets, trying to make notes in the margins, et cetera. So, technology has an important role to play, I think, but ultimately it has to be about understanding the existing model that's in place. You're not designing from scratch, and really just trying to fill in those gaps from a workflow perspective so that, we often talk about it in terms of, system management, patient flow. How are the right patients going to the right care at the right time? And, we have a role to play in that, but predominantly that's about making the existing system, work more efficiently.
Mm-hmm.
Yeah, I'd echo something similar. So technology is a tool, to facilitate the right type of interactions. They're getting the right professional in the right place. They're making it easier for patients to access. It's making it feasible to manage clinical workflows in a more effective way. But there isn't, to transform, the transformation that I think will happen in the healthcare space over the next decade or decade and a half will be tech-driven or tech-enabled, but it isn't going to involve inventing any new software that hasn't been invented anywhere else or any new technology. I mean, what we're doing as a company, which so far is off to a pretty robust start in terms of the impact we're having, we didn't invent any new software to do it. We wrote a lot of code. We developed a bunch of tech tools. We spent quite a bit of money getting our platform together, but it wasn't, no one in the software space would see us as a leading innovator. And I think that's the right way to think about it, is how can technology that's already out there be applied in ways that make sure that the right care professional is seeing the right patient at the right time, that information is being shared appropriately and so forth. And there's incredible opportunities in this space. It has, I don't think it's be a surprise to anyone, it's developed more slowly. Jonathan Bush, the former founder of Athena, says that healthcare is the only space that's seen negative productivity, labor productivity growth over the last 3 decades. As most of the rest of the economy has been transformed by the IT revolution, it doesn't seem to have happened in the healthcare space. That will change. It isn't going to require the most innovative software engineers in the world to do it. It's going to require, I think, a bunch of people in collaboration figuring out how to apply stuff that's been developed appropriately to the problems that exist in the healthcare space.
So similar themes. I mean, I see technology kind of in 2 ways. One is an enabler for scale, really important for that. Second is, for us at least, the technology team at CityBlock doesn't have a healthcare background. So they're not constrained with sort of like all this noise about why things do or do not work or can't happen. And so being able to merge sort of people that have done it in another world and put that lens into a healthcare space, I think is really healthy. Of course, they need to learn the healthcare space, which is another challenge. But I guess I would say at the end of the day, I mean, our fundamental belief is this is about building trust and engagement in populations that the system has let down. And like technology is never going to build trust and engagement with people. So technology can take it once you've done that initial front work, but like the amount of time that you have to spend building that relationship so that then you can be off and running with a patient population is significant. And it's only then that technology is going to be able to help you then work smarter and work faster. But it's, at the end of the day, this is a human play, in my opinion.
So, the question that always comes up at the end of any discussion when it comes to Medicaid, there's one thing you could change, right, in Medicaid. What would it be? So, Melanie, you can go first.
I already said I would change the financing formula. I have all sorts of ideas on how we might do it differently. And just that is the number one thing I would change.
Justin?
I just think the accelerating the rate of innovative new care delivery models and changing the incentives, particularly at the MCO level, to innovate quickly would make a big difference.
Yeah, and I would say the contracting process, just speed to try out new initiatives, especially ones that are more ancillary rather than your core programming, digital health being kind of the prime example. How do we go towards things that we can actually get to market quickly? Because if you wait, a year and a half, 2 years to take it to market, the technology is already going to be, slightly out of date.
Mm-hmm.
Can I add one thing?
Yeah.
I also think actually we also need to figure out ways to let private sector or nonprofit sector, anybody outside of government kind of give advice to people inside of government and vice versa. So in federal government, you have these things called details where you can go to different agencies or you can go outside the government. And it's super valuable because you get different perspective. Imagine if we could create some program where you had people from health plans or provider organizations or advocacy organizations that could sort of detail or in government for a little while, and government folks could go out, because I just think it's eye-opening. It was eye-opening for me to leave government and get on the side of a regulated entity and think, oh my gosh, I can't believe I made these decisions that made that life so miserable. Yeah, yes. When you're inside, like there is a reason. People on the outside think you're just like ridiculous or dumb or lazy or whatever. Like there's a reason most things happen the way they do. So it'd be really valuable, I think, for outside folks to get view on that too. And people claim there's like conflict of interest and all other stuff. I'd love to figure out a way that we could solve that perceived or real conflict of interest and have a much more two-way learning. Because I just think it could help. It could help in so many ways, both for the policymakers and then for the folks that are trying to innovate outside of government.
I often joked in Ohio when people would come to us and say, why does it take you so long to change this rule? Because in Ohio, when you want to do a rule change, it took 1 year from once you started the process to when you were finished. And along the way, just understand there's legislative review, there's governor's office review, there's a whole bunch of steps along the way to have it like that. And that's how government works. And there's a reason for it. Because I said, you're on my case right now because we're trying to do something you want to do. What if I was cutting your rates right now? Right? Then you'd be like, oh, a year's too short. You know, it's like we want a longer period from that and moving through there. And how do you make those things happen like that? So I do want to reiterate what Melanie said. Having myself worked on both sides, 2 times, it is interesting. It gives you a good view of what's going on in there. And there's good reasons for it. Now, there are also a bunch of bad reasons. Mel and I have worked together, and when we were launched the duals program in Ohio, we fought a lot of issues along the way. How to push that forward and making the change there. And there were some very dumb rules on my side that I had to work through it and get rid of, but it's how do you make those balances going through there. So with that, we're at time, so I want to thank the panel very much. Thanks for coming and telling us your stories, and if we could all thank them.